Hello everyone, my name is Dr. Paul Stricker. I'm excited to talk to you about something that is common for most of us. We see a lot of this patellofemoral dysfunction in the pediatric patient. So the disclosure, I am a paid health advisory board consultant with the Juice Plus company and don't have any unapproved or off-label discussions today. So we think about general concepts. Anterior knee pain itself, of course, is very common among active young people. Many causes, of course, you can have pain from just falling on your knee, but as more common is overuse and the mechanical imbalances that are in this child or a particular patient with inflexibility, muscle imbalance, etc. And then whether or not they're going through their growth spurt can add all sorts of issues and certainly can cause some anterior knee pain. Most of the conditions respond well to physical therapy exercises. And then just don't forget, just because it's their knee, we do have to remember that we have to check their hip, of course, and make sure that's okay. And then also check their feet because foot pronation can also be a contributing factor. So patellofemoral dysfunction. In the majority of cases, it's not traumatic. Occasionally, you'll have a child that will fall directly on their knee and then they'll develop pain under their kneecap. But as far as this discussion, it will really apply to the non-traumatic forms of patellofemoral dysfunction. Some of them may have had a change in activity or a recent growth spurt. The pain is usually somewhat chronic and intermittent. It's uncomfortable, but usually they can get through their activities just fine. A lot of times they'll complain about pain with stairs, so not even just with their sport, but like if they're going up and down stairs, or if they're sitting for a long time, or in a long car ride, or at the movies, or if they're running, all those things can cause pain. They may feel like their knee wants to give way or is wobbly, or they'll feel like it's going to buckle underneath them. And the pain is usually more diffuse. A lot of times, by all means, if a child has tibial apophysitis or Osgood-Schlatter's, they can take one finger and put it right on their tibial tubercle and say it hurts right here. With patellofemoral dysfunction, it's usually more of, when I ask them where's the pain, they just kind of draw a big hand circle around their kneecap and say it's kind of around here. And then if I have them narrow it down, you know, well, if you cut it in half, is it more on the inside or the outside of your knee? Then they'll usually point a little bit more to the medial aspect around the patella and some inferior aspect as well. They may have a little bit of soreness on the facet of the patella, the retinaculum, which is part of that medial patellofemoral ligament, as well as the fat pads underneath the patella. Typically, they have no swelling. There's no effusion in the knee. But a lot of times when I ask them if they've seen swelling, they will often say yes. And that's because many patients and their families confuse enlarged fat pads with swelling of the knee. So when you look at this next slide, I've pointed out the fat pads. And so a lot of times when they're lying down or they extend their knee and the quad contracts, pulls the kneecap up, it will compress the fat pads out as the patella tendon gets stretched. And a lot of times people will think that that's swelling, or if those get larger with activity, then because they're getting pinched or whatever, then they can also think that that is swelling. But if I put my cursor here, the dimple basically on the either side of the patella is where we actually look for effusion in the knee joint. So not at the fat pads, but much more around here. So one of the most common causes of anterior knee pain is patellofemoral dysfunction. Now, even though it is more common in general in females, believe me, I see tons of young males that have patellofemoral pain as well. What's interesting is that this triad of mechanical factors is a really foundational basis for most causes of patellofemoral dysfunction. They get overcompression of the patella due to muscle inflexibility, primarily of their hamstrings, quads, IT band, hip flexors. And then they also have maltracking of the patella due to muscle imbalance. The outer quad pulls much more than the inner quad, and it causes maltracking of the patella. And then what their foot does, if they pronate, that causes its own set of mechanical issues that I will discuss in detail as well. But interestingly, even though there's a mix of females and males, I do find overall that it's a little bit different for each of them in the fact that most females the biggest part of their issue is the muscle imbalance component of the patellofemoral dysfunction. Whereas with males, the majority of the time, their biggest issue and factor is the inflexibility part. So even though both females and males have all three of these, it can be a little bit weighted and different depending on the sex of the child. But again, it's not always a hard and fast rule. So my wonderful drawings for you here. But when we see on the slide, I'm sorry, the picture on the left, when you think about the force of the quad pulling up and the hamstrings pulling backwards, then those forces that just the resultant force is that patella just gets compressed really hard on the femur. And so they get a lot of that rubbing under there, which is very uncomfortable and sometimes can make it feel crunchy or noisy. The photo on the right takes us back to high school physics. But I think it's very applicable here because it really is important on how physical therapy can benefit these kids. So when you look at the picture where the vastus lateralis, the big outer quad muscle, is very big and strong, and when there's a little force coming from the VMO or the vastus medialis obliquus, if you complete the box and draw that resultant force vector, it still shows that the patella is going to be pulled up and out into a lateral maltracking situation. And so that's why even though the VMO, that smaller inner muscle, will never be as big or as large or as powerful as the large lateral quad muscle, the vastus lateralis, if we just improve the strength of that muscle by about 25%, you can see how the force vectors change. The force for the VMO is now bigger. And so then when you draw the enclosed, finish the rectangle and draw the resultant vector, the kneecap is going to track in a much more neutral positioning, which can be very helpful. So this is how some of these mechanical forces really do play a role. Now, if there's significant, dramatic overcompression of that kneecap on the femur, sometimes the child will get what we call an inhibition response, where the brain basically shuts the quad down temporarily, and that's why they will have this dampening effect where they feel like their knee is going to give out on them, or it'll buckle, or they'll have to catch themselves suddenly. So these are reasons why this particular type of symptom occurs. So when we're talking about the flexibility of their quads and hamstrings, it's very important to actually be able to test for this, and it's very easy. So when they're lying down, I will start with the leg flexed to 90 degrees there, so along here, and then I'll raise the foot up passively until I take up the slack in the hamstring and I reach that point of resistance where I can't really go more unless they helped me. And so technically, the measurement then with what's left over is the actual measurement for that type of flexibility. But for me, it's just easier to remember that, hey, if I only got 60 degrees from horizontal here, or if I only got 30 degrees, which is most of the time what I see, then I know that these kids' hamstrings are very, very tight. Similar, the quadriceps, if they're lying prone and they're totally relaxed, as I take their foot from horizontal and start to raise it up, I'm watching when their pelvis starts to shift. And as soon as their pelvis starts to shift and rotate slightly, that's where I know that I've taken up the slack of that quadricep, and that's where I kind of measure that flexibility. Most of the time, the pelvis is not supposed to shift until after you get the knee past 90 degrees of flexion, like in this picture. But I will tell you that most of the patients I see with patellofemoral pain, they are not close to even getting close to 90 degrees. So that's another way that you can really do these kids a favor, is to check the flexibility. And in many cases, you know, they may not be the same on each side either, so they have some catch up to do. Now, this is a picture of significant maltracking of the patella. So where the quad is relaxed on the left, I've put a dot in the center of the kneecap and then the anchor on the patella tendon. And you can see then when the quad contracts, that kneecap, that dot goes almost horizontal. And then when they release it again, it goes straight back. So again, that's significant maltracking rather than we want much more of an upwards type of movement of that patella. And then foot pronation, how does that play a role? Well, it's a kinetic chain that goes all the way up. So once that foot pronates and that arch drops, that causes internal rotation of the tibia. And it also causes the knee to slightly go into valgus, but it also, as that tibia rotates, don't forget, the patella tendon is attached right there on the tibia. So if that rotates, the patella tendon rotates with it, which then changes the angle of that whole patella tendon complex, which then also kind of wants that kneecap to continue to go up in a lateral maltracking type of situation. So foot pronation does cause a significant role in, or play a significant role in patellofemoral dysfunction. So I always look at the feet. So in this case, the child is standing on one foot, but then when I ask them to relax the foot, you can see how the arch definitely drops pretty dramatically. So overall, when we're dealing with patellofemoral dysfunction, obviously that's an accumulative effect of all of these mechanical factors. There's the overcompression of the patella due to inflexibility. We talked about the quads and the hamstrings pulling, so it compresses the patella, but don't forget about the IT band. If it's super tight, it also causes a lot of lateral tilt to the patella. And so that can also play a significant role as well. So when we're talking about overcompression from whatever reason, oftentimes that rubs underneath the patella and causes pain, and then can also overcompress those fat pads, causing fat pad impingement, which is painful. And rarely do we ever get MRIs for patellofemoral pain, but if we have a child that isn't responding to months of physical therapy and is making progress but is still painful, the MRI often will reveal a lot of edema in the fat pad, showing that there's still a lot of fat pad impingement that is occurring. The maltracking of the patella due to the muscle imbalance, as we spoke about, then that can also offset the kneecap in its kind of triangular position in the groove of the femur. And then that not only causes rubbing and pain, but also pulls on that medial retinaculum ligament around the medial side of the patella, causing discomfort as well. So as the vastus lateralis pulls against that weaker VMO, then you get that lateral tracking. And then a lot of times we'll see weakness in the gluteal muscles by having the child stand and do a one-leg mini squat. They'll basically just stand and squat about 3 or 4 inches. And what you can see is if there's some gluteal weakness as well, that their knee will tend to kind of want to buckle inward into kind of a valgus situation. Their knee won't go right over their foot. So that's why a lot of the treatment will involve the gluteal muscles. And then foot pronation, again, as we talked about, rotates the tibia and affects patella alignment. So treatment-wise, if we think about those 3 main factors of patellofemoral dysfunction, then those are the things that we want to address, right? We want to really work on flexibility of the hamstring and the quad and the hip flexors and the IT band. And so I'll have these kids talk, I'll refer to it as, this is not a sprain where you do physical therapy and some exercises for a few weeks and then you're back to where you were. These are mechanical issues that aren't going to go away with just a few weeks of stretching once a day. So I want them to realize that not only the longevity of this issue, but how much they really have to be involved in this on a regular basis. So flexibility, I'll remind them, hey, after you've done your sports or your exercise activity, that's when you're the most warmed up. Take advantage of that and really stretch before you get in the car to go home. Also stretch if you can before you go to bed so you don't tighten up so much in your sleep. And then we talk about, not just stretching, but what do you do ahead of that? You can kind of meat tenderize the muscles by doing some massage, or get on a foam roller, or get out mom's rolling pin and roll out the muscles to try to do that before you do your stretches. So all those things can be quite helpful. And then we do specific exercises to improve the strength of the VMO and the gluteal muscles, because it's not just that little VMO that matters. The gluteal muscle also plays a big role in helping the 2 of those muscles compensate for that large force from the vastus lateralis. Please address foot pronation with either arch supports or inserts in their shoes. I'm not promoting any certain brand, but there are some good over-the-counter orthotics such as Superfeet and Spinco that can be used to help these kids keep their arch supported so that they don't cause that as another effect of their patellofemoral dysfunction. Now, people often ask about custom orthotics. They can be great if a child is really involved in their activity, is going to be doing a lot of running and impact type of activity. But again, for me, if I see that a child has not gone through their growth spurt yet, or they're in their growth spurt, I often will see if they can hold off and just use these over-the-counter inserts or orthotics until they have stopped growing and their foot size is not going to change anymore. Then that way they don't just get a $350 pair of orthotics and have to change it 6 months later. What about a knee sleeve? People say, oh my gosh, you know, can I wear a knee sleeve? Well, first off, yes, you can wear one, and you certainly want to make sure that it has a hole in it so that it's not causing more compression on the patella. But I also remind kids that the knee sleeve is just there to help them maybe get through their sport or their practice a little bit more comfortably. But it's never ever a substitute for doing the actual stretches and strengthening that's involved to help overcome this problem. Because if they just slap on a knee sleeve and they go on their way for months on end, then the knee sleeve actually kind of takes over, and so they actually develop more weakness, and they start to depend on the brace, and it just doesn't really give them the long-term benefit. So if they're going to wear it, I emphasize that they must be doing their exercises, because then the brace can be used temporarily as a support system rather than anything else more that might be a negative thing if they overdo it. And then, of course, if a child is in their growth spurt, then you got to remember that during that most rapid phases of growth, we really want to put the main emphasis and priority on flexibility rather than on strength. Because if a muscle that is getting so tight so quickly and causing so much compression is then suddenly made even stronger, it's just going to cause more compression and more discomfort, and I think it's going to backfire. So if I have a kid that is really in the midst of their rapid growth, I will make sure that the physical therapist knows, hey, right now just spend 90% of your effort on flexibility, and then after that gets better, then we can start to work on strength a little bit more. Now, it's important, like anything in medicine, but to distinguish that you truly have patellofemoral dysfunction pain rather than other common causes of non-traumatic anterior knee pain. Patellofemoral pain, again, is a much more diffuse kind of peripatellar anterior knee pain versus a focal pain, and like Osgood-Schlatters tibial tubercle apophysitis. So use that history. Use your physical exam to give clarity to your diagnosis so that you really feel confident about that. So for instance, patella tendonitis is more focal pain at the posterior inferior distal pole of the patella, which again is not over the tibial tubercle apophysis, but it is on the end of the kneecap, but basically underneath the distal pole of the patella. It's common in jumping sports with increased eccentric loading when they're landing from a jump, and that muscle is contracting at the same time it's being stretched. Usually it occurs after the tibial tubercle apophysis has fused, so the stress no longer gets taken up by the open apophysis, but it gets transferred into the tendon. And then it's best found when the patient is lying down, the leg is relaxed, the distal pole of the patella is tilted up, and then you palpate directly under that. And so here's the visual. So you're going to press down on the superior aspect of the patella, which tilts the patella up, so that you can actually get your finger underneath the distal pole, where that tendon basically kind of inserts around that backside of the patella at the tip. And so it's easier to really narrow that down. And if they are really painful there, that's a much more common place that you'll find patella tendonitis versus Sinding-Larsen-Johansson apophysitis. This is focal pain at the distal patella, just like patella tendonitis, but it's on the anterior aspect of the distal pole of the patella. And it's a growth plate, it's an apophysis, so it's only during the growth phase. So it's commonly during that 10 to 14 years of age, whereas patella tendonitis doesn't really matter whether they're skeletally immature or not. It's a traction apophysitis, just like tibial tubercle apophysitis, and common in jumping sports and those with fast starts and stops. But the radiographs help with the diagnosis in this case, because in that, if you have a lot of point tenderness that they're not getting better with normal routine types of programs and stretches and strengthening and activity modification, then the x-rays can be helpful. And here you'll see then you have this apophysis that's on the anterior portion of the distal pole of the patella. And oftentimes, pain at this area can take a little bit longer than patella tendonitis just because it's a skeletal issue. And like tibial tubercle apophysitis, that growth plate is not going to close anytime really quickly. And so they have to work on ways to decompress that by getting their flexibility better as well. When we think about patellofemoral knee pain, then it is one of the most common causes of anterior knee pain. It's a mechanical problem more than an injury. So again, it's not going to just get better in a few weeks like many of the injuries do. It's a mechanical problem. It takes a lot of work and a lot of consistency. Most often these kids can maintain their activities even if they need some modifications along the way. Physical therapy and long-term home exercise programs are very important. I always emphasize that just when you're discharged from physical therapy doesn't mean that you stop doing the exercises. The program will continue on your own for many months if you want to really get the full benefit. It literally can take many months for this to make a long-term difference. Over-the-counter orthotic inserts can be helpful. And then the history that you take also helps narrow down the diagnosis, as well as those key physical exam findings that then can help you with the treatment plan. And even though there's those three main concepts, you'll be able to know which one to emphasize more to be able to get that type of instruction to either their home program or if they're able to go to a physical therapist. So I'm hoping by now that, that patellofemoral pain won't be like abdominal pain and that you cringe, but it'll be something that you feel confident on, that now with these history and physical findings, that you will really be able to help provide these kids the necessary treatment plans that they need to be able to have a real successful outcome. Thank you so much.